All right, well, I want to do a welcome. Welcome to the latest presentation in the National Telehealth Resource Center webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. Next slide, please. Located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serve as focal points for advancing the effective use of the telehealth and supporting access to telehealth services in rural and underserved communities. Next slide. Just a few tips before we get started. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Today's webinar is being recorded, and you'll be able to access today's and all our past webinars on the National TRC YouTube channel. And the next slide. Today's webinar on inpatient asynchronous eConsults will be presented by or hosted by the Mid-Atlantic Telehealth Resource Center, and I'm Kathy Wibberly, director of that. And it will be presented by Kim Dowdell and Sam Collins at UVA Health. And so I'm going to go ahead and punt to them.
Well, good morning and good afternoon. I know we have folks from all sorts of different time zones here. By way of introduction, for the purpose of today, Dr. Dowdell and I were hoping that this can simultaneously serve as an introduction to eConsults for folks who may have heard the term or be vaguely familiar with it, and highlight some of our experience with it thus far at the University of Virginia. But then also for folks who may have a eConsult program up and running, we can have some lessons learned during this time of COVID, and then also in an expedited fashion, standing up our inpatient eConsult service, which was new for us and then also new for nationally as well. So a lot of folks really working hard during the pandemic to stand that up. So we will move on now, and some of this will be specific to University of Virginia, and then some of it is broadly applicable, and we'll do our best to differentiate those two. So we'll start with a definition. eConsults really create standard work for the curbside exchanges, and those exchanges are ones that have traditionally taken place a long time ago in the cafeteria and as hospitals expand, then via phone, via staff messages, and then of course the ubiquitous email consults back and forth. And now with the prevalency of the EMR, also within staff messages. So I think eConsults came about in a way to say, okay, how can we capture this work that's already being done, and how can we do so in an efficient and guided way? There's a lot to say about what an eConsult's not. I think when people hear electronic consult, there's a lot that comes to mind, and there's a definition that's emerged probably over the last decade about what an eConsult is. And some important things to note. So far, it's generally been low acuity, low complexity things that have been targeted. Its intent is often to avoid suboptimal referrals that could have been answered completely asynchronously, which means that the consulting provider still owns that problem. The specialist or whoever is answering the consult is not taking a handoff of the patient. While it can serve a triaging purpose, it's not inherently meant to triage. In fact, just for an anecdote, for people assigning different definitions to it, eConsults is, a pretty wide-ranging tool. A GI doctor who's our champion for pediatrics wrote a 1995 paper called eConsults, Email Use for Provider-to-Provider Communications. So it's really important, and it's a little bit of a soapbox, but to have a working, clear definition of what an eConsult is and what it's not. So what are the benefits of an eConsult? We've already touched on formalization, but also with certain specialties having wait times that are at larger systems anywhere from 3 months up to a year, And then that's obviously exacerbated by services being stymied during these recent months. It's really important that we have the right patient in the right place at the right time. And so this provides some efficiency. Also, what I alluded to earlier about there being emails and about there being phone calls, every eConsult is now part of the record. So you have safe and then referenceable exchanges. And what that means is there's something inherently educational about that, whether it's the provider themselves learning to manage specific diagnoses, specific problems, or if you're actually using this to drive curriculum and forums. One thing that the AAMC encourages, and it's a model that we've adopted, is the co-management conference. And we've had specialists take 100 eConsults that they've gotten over X amount of time, and then they'll go to a house staff meeting or residents, or they'll meet with a small group of family medicine attendings or internal med docs and different primary care groups. And the exchange and the educational exchange will focus on actual questions, actual patient management that's come through. So it's not something esoteric, it's not something disconnected, but it's living an authentic curriculum. Additionally, this is a way to build relationships. At UVA, for instance, we have regional provider clinics, some of them up to a couple of hours away from, in UVA lingo, on grounds, which just means on campus or home base. And this is a great way for people to build those professional relationships, or people new to the health system that are working in a primary care role that may not have a lot of connections, to have a way that they can reach out for specialty input on their patients. So a lot of great benefits there. Dr. Dowdell, anything as a primary care provider that you think really stands out that you've seen in, gosh, I guess 4 years now of using eConsults in your practice? Not in your director role, but in your, she's putting on her primary care hat here.
Putting on my primary care hat. I mean, it definitely allows us to access specialty care much, much faster than we otherwise could, and really allows the patient to be involved in that process, because we get answers back really quickly and are able to move that patient's case forward. So
great. Oh, and one more thing, I mean, that we have time for, when Kim talks about it being patient advocacy there's a great story that we can tell, the abbreviated version here, where Kim used a change in family history to get a patient screened in his colonoscopy, and she was able, we caught the cancer early, and she was able to be screened and get in for the surgery and then be cancer-free within the window of the wait time that for the access time we normally have for Kim's patient, Dr. Dowdell's patient, to go from primary care into GI for that initial patient visit. And so obviously we deal with low acuity things, but primary care is inherently preventative. And so this does augment the scale of practice there. And that's just one really great example that we're proud of. So what's going on? This is a UVA specific slide. I'll let Dr. Dowdell chime in here in a second on how the primary care physician and the specialist work to develop a new specialty, how you bring them on board. But initially, we suggest starting with your high volume. So if you look at who we have in the lineup for pediatrics, we started with endocrinology, we started with GI, those high volumes, but there is a coalition of the willing. So we have some that we're really proud of that, you know, are some of the only ones in the country: toxicology, sleep medicine, and then we're also rolling out an ophthalmology program, and there's some image capture involved. And so the model is not all, you know, it's not a rigid thing, but it's applicable across specialties and can be customized to your health system. Kim, do you want to talk about the relationship in developing a specialty?
yeah, so we take a really primary care, specialty care integrated approach when developing eConsults at UVA. Our program right now is limited just to primary care physicians being able to order these, and primary care other APPs being able to order these. And that is so that the primary care physician stays involved in the care. We have situations where specialty to specialty eConsults do exist, but those are specially cultivated within the two specialties, and we also facilitate how to involve the primary care doctor in that exchange, because we think it's important that the primary care doctor remain in the loop. That being said, the primary care specialty interface, we really sit down and we talk about what are the primary care points of view in terms of what are the conditions we really wish we had better specialist access to. And then we talk to the specialists about what are some of the conditions that they're seeing in clinic that they feel are low acuity, that really could have been managed if they could have just talked to a provider about that particular patient. So with that in mind, we come up with several, and we'll get to this a little bit later in the deck, but we come up with condition-specific templates which help guide the providers to either order tests, ask certain questions, get certain studies ahead of answering or asking an eConsult. There's also some preliminary clinical guidance of, if this, then consider this before you even place this eConsult. So we've actually been able to curb some of the really low acuity eConsults even by allowing that clinical guidance to be there and be visible. We also direct providers as to what might not be needed. So in many cases, our orthopedic templates say do not order an MRI before placing this eConsult. We really just need x-rays. We want to be cost effective and contain costs through this program as well.
And it's and so something for people who might be a little more familiar with the consults, but that we're seeing emerge, even, as Kim alludes to, specialists know what the trends are that they get emailed about, that they get staff messaged about. And so there's an idea now floating around of the reverse eConsult. And that's where when a physician places a referral, based off the diagnoses, the team of that specialist team receives it and then sends back a reverse eConsult and says, hey, we're happy to see your patient, but heads up, it's 4 months, 8 months. And we've had a high success of helping manage this via eConsult. Have you considered using that tool for this specific diagnosis that you referred for? And so that's underway, and there's some pilot specialties there as well. So that's just something new and worth mentioning. So far, I just want to clarify that Kim and I have been giving background on what eConsults are. If you've joined us late, on what eConsults are and where we've been at University of Virginia, and mostly we focused on primary care to specialist in the ambulatory setting. And so we wanted to give a background on where we were and what eConsults are, but based off some of the chat questions, we will be moving into what we've done for inpatient. So momentarily here, Kim alluded to the templates a second ago, and this is a great place to talk about developing templates, why they're important, and then also what just makes for a good eConsult, both from clinical efficacy, but then also in fairly new to this year, what makes a eConsult billable as well. So Dr. Dowdell, do you want to talk about what you've seen for effective eConsult exchanges between primary care and specialists using the templates and how the back and forth works?
So as I mentioned before, we have for our ambulatory eConsults, we do have condition-specific templates, and these help guide the questions and the topics that we answer through eConsult. That being said, we really do a lot of work with our providers to make sure that they are asking a clear clinical question. So we try to assess for quality here and there and really work with our specialists to make sure that they're getting good questions. In kind of EMR times, a lot of the referrals are coming through these days as like refer to cardiology for AFib. well, what are you referring for? Are you referring for a diagnosis? Are you referring for management? Are you referring for a medication change? So it's been a real cultural change to really tell a provider, hey, you can't just use a diagnosis for an eConsult. You really need to have a clinical question. So, this is my patient, 65-year-old male with past medical history of atrial fibrillation. We can't get him rate controlled on metoprolol. What do you suggest we do next? And then the specialist has a clear idea of what the question is and is able to provide a better answer. Yeah.
And so also there's a plan at the plan if conversion needs to occur on the slide, which probably moves us into our next slide. And this is a bit of eConsult lingo, but there's 3 outcomes to an eConsult. It can obviously be answered, it can be converted, or it can be declined. And so we're going to briefly allude to what those are, but obviously answered is, the intent. A eConsult can be declined. Oftentimes we see them being sent to the wrong specialty. It'd be more appropriate elsewhere. But then sometimes people still think that this is a logistical tool that they can contact the specialty office with. With good training and good management, I mean, we don't see that very often, but that's just, it just should be noted if there's any specialists listening and thinking, oh, is this just something else I'm forced to do? There's always the option to decline or to convert, which is you review it and you say, I'm going to need to do a physical exam, or I need to see this person face to face. A new piece that we've been working on during the expedited COVID era is trying to get more granular with this conversion piece. Okay, you've done the image review. Okay, this person needs to be seen, but could we potentially schedule that through a traditional face-to-face telemedicine visit as well? So we're working on that granularity now. But that's the lingo: answered, converted, declined, up to the discretion of the answering provider. Anything to add there, Kim?
Yeah, I would just say that, like you said, it's always up to the specialist whether they feel like this person needs to be seen or not, and incorporating telemedicine into that option of do they need to be seen is fantastic. Most of our specialists will not do an e-visit with a new patient. We've just gotten into the realm of e-visits here at UVA. They're brand new to us, and so we're really only using those for established patients right now. We'll get into a little bit of the billing and coding with the inpatient, but I think it makes sense right now just to kind of say that right now at UVA, we don't bill for the PCP portion of an eConsult or the ordering physician code. That's because there are a lot of complications to it in terms of documenting the time and outside of a normal visit. So, but there are charges associated with these, obviously, if you're billing, and there are copays that are associated with them as well. That being said, a lot of the cost, they're much less costly than an in-person visit. So they are cost savings to the patient, there's cost savings to the insurance company, there's cost savings all over the place. There's even cost savings to the institution because you're able to bring in a higher acuity patient rather than that low acuity patient. So with that said, let's move on to what COVID-19 did for us.
And just to quickly iterate a couple of Kim's points. It was in the slides earlier, but there is a definitive impact for no-show rates. And we've seen at our institution, even just looking at eConsults that were converted to face-to-face, we saw double and triple, depending on the specialty, more likelihood of the patient actually coming into that slot from a converted eConsult. And then one thing too here, what we mean by close the loop, it seems kind of intuitive, but we had a medical school student who did a great presentation and got accepted to SGIM, but wasn't able to attend because of COVID. But following up how people communicate the eConsult result to the patient, whether that is through like a MyChart or whatever your patient portal is at your institution, calling them, delegating that out to your nursing staff, whatever it is, you have to close the loop and communicate the results of the eConsult with the patient, especially now, and that's what we're about to get into, since there's a required consent for the patient to know you're doing an eConsult on them because of the new billing reality. So that's just an important note for if you're interested in building one of these out, that's part of the training. So Kim has been leading our effort, both as a provider, but then particularly on the asynchronous front in the time of COVID. So I will be eager to hear all of this frenzy that we've had summarized here in the next 15 minutes or so.
So entering COVID-19, as everybody is fully aware, telemedicine became hot and front and center and everything in between. Everything became about telemedicine in what seemed like overnight. And that wasn't any different for us. Literally got a call on a Sunday night at home by my CMO and who said, Kim, we've got to get inpatient eConsults done and we need to get them done this week. The idea there was we were planning for a surge and we wanted to make sure that we had mechanisms in place that could keep patients safe and keep our staff safe, but at the same time being able to provide excellent care to patients who needed specialist input in a timely manner. So with that in mind, we got a working group together and we started hashing out kind of what the difference between inpatient eConsults and outpatient eConsults might look like. Next slide. So you just heard us talk a lot about our ambulatory eConsults. In that realm, we had specialties opt in. We do specialty specific templates. Like we said, they're typically low complexity patients. And we typically at UVA use 1 to 2 specialists to answer the majority of these, especially on the outset. And then we add in specialists as that specialty becomes more popular or the volume increases. They're answered in 72 business hours on the ambulatory side. And as we discussed, the specialist always has the option to convert to a face-to-face visit. When we were thinking about inpatient, we really had to decide what were we going to mirror the outpatient and make it exactly the same, or were we really going to kind of take this with a different stroke? And after a lot of discussion, we decided that because the patients themselves were obviously hospitalized and more medically complex, the opting in didn't make sense for this case. So we decided to go all in for inpatient. We turned it on for every specialty at the same time. Because we did this, we felt like we didn't have the time, nor did we think it was appropriate to have templates. It's hard to anticipate all the different possible clinical scenarios for the inpatient world as opposed to the low acuity outpatient world. So we decided to go with a no template approach here. We recognize that every consult attending fellow and resident would need training on not only how to submit these, but also how to answer them. We obviously had to increase or decrease the turnaround time so that the results were expedited. We still recognized, however, that the specialists really needed to be comfortable doing an eConsult, and if they felt that that patient needed to be seen, that they always had the option to convert that eConsult to a face-to-face. And then the other thing that we felt was important for our inpatient eConsults was that we maintain the current consult culture. And what I mean by that is at UVA, the teams always talk to each other. There's very little that's actually communicated solely in the medical record. In fact, our process for calling a consult is actually a call. You know, you submit the eConsult, or sorry, you can submit the consult, and then you drop a courtesy page to the fellow or on call to say, hey, I'm consulting on Ms. Smith, give me a call back, we'll talk about what the question is. So it was important that we maintain that culture to our working group. Next slide. So the first thing we recognized was, as I think Samuel alluded to in the very beginning, you really need to standardize what your terms are when you're talking about these things. Since the ambulatory eConsult has existed at UVA for the last 5 years, we decided to use the word eConsult to really mean what we had been using it for in the ambulatory space, which was an asynchronous documentation only encounter. And so those are the 99451 through 99452 codes. part of a larger set of codes that are called interprofessional consult codes. So if you look this up in the billing and coding manual, you're going to see all of these as under the kind of same title. But for getting everybody on the same page, we felt we really needed to keep the eConsult as this asynchronous documentation only. And then we called the other consults IPC. And what these are the 99446 through 9 series. And these are a verbal report and documentation. And so we just kind of set this as our nomenclature moving forward, so to create less confusion among all involved parties. Next slide. Oh, go ahead.
Kim, it's probably in the slides, and but just by way of background, the billing codes. Do you want to give a brief interlude about Medicare in early 2019, and then what's changed during COVID with other payers coming on board?
Yeah, so for Virginia, we've been slow to adopt these codes commercially. The codes were first created by CMS in 2019, but at that time, only Medicare started covering them in the state of Virginia. We didn't have any Medicaid or commercial, really any of our big commercial insurers covering them. In April of 2020, with COVID's help, we got word that most of our commercial insurers were covering it, and then in May of 2020, Medicaid also announced that they would be covering these codes. So that was obviously a big push for us to start billing for this work. So when we're developing the inpatient eConsults, we really just had to kind of define what were our two buckets of consults, if you will. So we labeled these traditional or video consult, and then versus the eConsult or interprofessional consult. The traditional was what we had been doing prior to COVID-19, which is, you have an inpatient, they need a specialist to weigh in on the case. You call the specialist, they come, they see the patient, they write a note, they talk to the team, and then that care gets implemented. We were lucky that we had some technology readily available to develop telemedicine or televideo. I use the term televideo to make it very clear that it's a video, and that allowed us to have the specialists outside the room, perhaps, of a person under investigation for COVID or a COVID positive patient that they could do a full consult with. And we just had them do their normal workflow for those types of things and just add a brief kind of this is our smart phrase that's embedded in this slide here, but .tmed, which basically just documented that there was a use of telemedicine equipment for that particular interaction. Like we said, the eConsults and the interprofessional consults were really designed to keep our providers safe, but they were also designed to recognize that some of our providers were on the at-risk spectrum, if you will, and so maybe they didn't want to be going into these rooms or coming into the hospital at all, but still wanted to be contributing to patient care by being able to be available for this type of work. So the big thing to know with these, and we'll go into a lot more detail about this, is that they are time-based codes. They are not complexity-based codes. And the time is all central around the specialist, or in our case, since we're an academic institution, the attending. So you don't take into account any of the time that the trainees or medical students or whoever might be helping with that consult. It's solely attending time. Next slide. So special considerations, we wanted to be able to make sure that we had a workflow in our EMR, which we use Epic, to make sure that the consult could be answered directly without involving the patient. But also still make sure that we were satisfying our academic mission by being able to involve trainees where it was possible. We always wanted the specialist to maintain the ability to convert a visit if needed. And we wanted to make sure that we emphasize to our specialists that this type of consult can only be billed once every 7 days, and that they can't have a visit with that specialist within the 14 days around the consult. So I'll get back to that a little bit later, but that's an important point to remember as you're launching these.
And Kim alluded earlier to the 72-hour turnaround time that we have, that there's the expectation on the ambulatory side. We typically, I mean, our average eConsult response time is right under 24 hours on the adult side and something like 14 or 15 hours turnaround time on the ped side. But we did have to make some changes of expectation on the inpatient side. Kim, have you alluded to or mentioned turnaround time on the inpatient side yet?
Yeah, so turnaround time on the inpatient side is under the same turnaround time that we would expect for a face-to-face consult. We didn't expand that time at all, and typically at UVA that occurs within a few hours between the call and getting staffed, but always within the same day. So this is just a workflow kind of diagram of what happens when the primary team realizes that they need a specialty e-consult. We really decided that the team could indicate which way they would like the consult to go. But as you can see with kind of that orange arrow, it's really up to the specialist if they want to convert that inpatient e-consult to a consult order. So it's at the time of ordering that our team decides which one they would like to do, and they either pick an e-consult or a regular consult. And then per our kind of culture of consult here at UVA, they're going to give that specialist consult pager a quick page and likely a phone call about what's going on with the patient and that kind of thing. Depending on how the specialist sees the case kind of in that first interaction, they'll decide whether they want to answer this in an asynchronous fashion only, which would be documentation in the electronic medical record with a note, or if they want to do some documentation and then the attending call the team back and give a verbal report. Obviously the last option would be that they felt the patient was too complex or would need more than one kind of subsequent day follow-up, and so they could then convert it at that point. So the big thing that we had to emphasize to our team here at UVA was really that the major change in billing is that all of these are time-based codes and really dependent on the role of the attending, being that we're an academic institution, in the care of that patient. So, different from a face-to-face consult or a telemedicine video and audio consult, that is really about the complexity of the patient, versus these codes really, it's really about how much time that attending is spending and reviewing the chart, doing the documentation, providing the recommendations, and that kind of thing. And then again, with the eConsult, all of that would be done electronically, and with their interprofessional codes, those would be done with a verbal communication by the attending. So in an academic institution, a lot of the times the communication's done with the fellows, and so we really had to drive home the fact that the fellow could definitely contribute to the case, but the billing would not reflect the fellow work.
And Kim, you've done a great job of outlining the billing process on the provider end, but do you think we should talk a little bit about what the potential is? I mean, we're in uncharted waters here, but for the patient billing side of things with the copay, and then also how our billing department is holding the charge for that 14-day parameter.
Yeah, so it's a little bit different for inpatient and outpatient. Inpatient eConsults will be bundled in with their hospitalization. So I don't foresee that there'll be a copay necessarily. Like, they won't get a separate bill for the copay. It'll be part of their hospitalization bill. For ambulatory eConsults, there are copays that it's unclear right now with COVID, with waiving a lot of the different kind of copays, what we're going to be able to do with those, and it's changing on a daily basis. So for right now, our billing department is holding all eConsult charges for 14 days, both inpatient and outpatient, to make sure that an eConsult didn't get converted over kind of 3 days later, or a patient didn't get seen 3 days later. Of course, we're only aware on the outpatient side, we're only aware of patients who are seen in that specialty in the next 14 days if they come to our hospital or our outpatient clinic. But at least on the inpatient side, we're holding those because we've had a couple instances where the team, the patient was under investigation or they were COVID positive, and the team got a eConsult at that point in time, and then something with the patient's status changed, and now they needed more to be more closely followed. And so now the regular consults are taking over. So by having all of our eConsults held at the billing site for 14 days, we're hoping not to submit erroneous bills. So this is just to kind of further delineate the difference between the two codes for everybody. The 99451 is really just a documentation code. It's all about the time spent in review and documentation. You can use this code with trainees. You just have to spend more than 5 minutes as the attending in order to bill the code. The interprofessional codes, 99446 through 99449, they are the ones that require the attending to do the verbal documentation. So at our institution, where the culture is kind of that the trainee or the fellow communicates primarily with the team, our attendings mostly were charging or charge capturing the 99451 because they weren't actually doing any of the verbal conversation. So that's just one point to keep in mind if you're thinking about launching these at an academic institution. So this is a really busy slide, but kind of contains all of the nuts and bolts of, how much are these codes being paid for by some of our local insurers, as well as what are their RVUs and what are the rules around them. I'm not going to go into a lot of any of this slide actually, but we just thought we would provide this information because it is important that you understand these rules if you're thinking about launching the program.
And just briefly, and it's not to dig deeply into the slide, but Kim, do you want to speak about the role of RVU credits and what's been allotted just momentarily?
Not really.
Okay, that's fine. But that was part of the Medicare. That was part of the Medicare output, was that they came up with the RVUs, and so it's something to calculate and keep in mind. Again, Kim's right. Busy slide.
So lessons were learned. Our biggest lesson that we learned, pretty much out of the gates was what we had for outpatient wasn't going to translate over to the inpatient model very quickly, and we kind of realized it shouldn't. You have to think about, is this going to be an all-in approach, or are you going to allow for selected participation? You really need to get everybody on board with what the different terms are at your institution so that everyone's speaking the same language. I think what we learned off the bat was that communication's hard in a big academic medical center where you've got different organizations and things like that. So you can't over communicate about this, but you also need to provide training. We provided epic tip sheets. We provided a PowerPoint presentation when we launched this. We did a CBL, and I still don't think we did I still think we could have done more. And so you really need to get into this cycle of communication training, and keep going with it. We just did another communication training thing today at lunchtime to kind of reemphasize what's been happening as we've been starting to submit these bills, and kind of lessons learned and what providers need to know moving forward. And the last bit would be that you really need to make sure that you're tracking the use of these to make sure that they're being used appropriately. We learned in the beginning, we had one person who didn't quite understand that the eConsult couldn't be billed every day, and so they were there kind of dropping that charge every day when they really should have been dropping a consult charge every day. And so because we had an ability to see that, we could stop that provider and kind of make sure that we did a better job explaining what the purpose was.
And coordinating with your data and analytics team and who's putting out your EMR reports at the onset is the ideal state. And Dr. Dowdell and I were fortunate enough on our ambulatory side to have really robust and great reporting, right? I mean, we could see who did what on a given day, and we were tracking the turnaround times. And but this was so expedited, and as you can imagine, I'm sure it's been the same at your health systems. The EHR team was just pushed to the limit like everyone else was and putting out fires. So asking for a robust report for inpatient eConsults to be built out that was available in, say, a reporting dashboard with less than a week's notice just wasn't feasible. So our quality control wasn't where, or isn't, I'll say, I mean, we're still in the midst of this. That'll age well. But I mean, our quality control just wasn't as robustly built out, but that was, we had to make that concession just to get it rolling. And so that's just, if you have the time to do this, you know, make sure that you've coordinated very closely with your data and analytics team.
Yeah. So last slide, you know, if you're thinking about this, why now? We basically know that this is all work we've been doing and will continue to do. We're trying to capture it as much as possible right now. Our institution has had a huge reduction in ambulatory appointments. And so from the ambulatory eConsult side of things, it makes sense to have this program in place because we know that our access time is just going to go out further, even though we're using other ways of kind of getting patients in with telemedicine and things like that. We know that patients are avoiding coming to our hospital. Our ER volumes are down, our ambulatory volumes are down. So the more that we can do that's with telemedicine and is asynchronously done, the better is our standpoint. COVID, I think, has really revealed how much we can accomplish electronically, and the old way is no longer sufficient. And kind of what I've brought to our leaders here is, if we're not in this space as the large academic medical center, then who's going to fill it, because it is a space to be filled. From the inpatient side, it just makes sense to have this as an option. I wouldn't switch all of your consults to eConsults. That doesn't make sense at all, but it does make sense to have it as an option for care in patients who need it. And especially knowing if you have a provider mix, we have some of our providers who are over the age of 70, but they're still some of the leading experts in the field. They may not want to come into the hospital, but they can certainly still provide some of their expertise. So this gives them a way to do that. So I guess
Great, thank you, Kim and Sam. So we have a bunch of questions in chat box, so I will float them to you one at a time as they came in. So first question was, how is the cost of an eConsult compared to a regular in-person one?
Yeah, so the eConsults, the CPT code for the eConsult 99451 is a work RVU of 0.7, and that translates in Medicare dollars to about $37. So significantly cheaper than a in-person face-to-face visit. I'm not sure of the comparison with what the consult code versus the eConsult code is for inpatient. I'm not as familiar with that. But for the ambulatory space, it's significantly more cost effective for the patient to have an eConsult done.
And just to add to that, I mean, for numbers purposes, we have tracked the time spent on our ambulatory eConsults, and something like 85% of eConsults are answered in 15 minutes or less. So that's important to note too, for just the efficiency and how many you're seeing and how long it takes you to do the work.
Great, thanks. The next question is, will specialists do e-visits with new patients?
Not at our institution, at least not right now. Like I said, e-visits are a new entity for us. We weren't doing them prior to COVID. We're starting to dip our toes in the water right now, but we're really just offering those to established patients at this time.
All right, our next question is the patient subject to a copay for these services from both the requesting provider and the consulting provider? And if the requesting provider bills for their code and then the consulting provider bills for theirs, are these two separate copays required for that one case?
Yes and yes. So this is the difficulty with the 99452 code, and why honestly we're not billing for it yet at UVA. We kind of think it's a little crazy to be getting two copays for one question, if you will. And so I know there's a lot of advocacy out there to kind of readdress some of this, as well as readdress kind of what the time is for the 99452, which is the ordering physician code. That code explicitly states you have to spend more than 15 minutes in the developing of the question for the specialist and
Outside of the encounter itself.
outside of the encounter, and doesn't address the time that you spend when you get that response back, communicating to the patient what the response was, what the plan's going to be moving forward, and things of that nature. So we've made the decision here, at least for right now, that we're not going to be billing that 99452. So that eliminates that copay. There are copays associated with all of the interprofessional communication codes. So that's the 99446 through 9 series, which is the verbal conversation and written documentation series, as well as the 99451, which is what we call our eConsult code.
And the PCP continues to get the RVU credit for the work at UVA, and that's important with targets in mind. And then additionally, and we don't need to split this up too much and detail too much about it, but many institutions are considering for right now, for practicality purposes, a split payment for that single billed code from the specialist that's shared between the primary care physician and the specialist. So that's one model and one way of doing it that people, or not people, but institutions and people are considering.
Great. Our next question, how are you choosing your pilot sites and what platform will you be using for your pilot?
Yeah, so
clarification on that one.
I think that was in regards to external eConsults.
So external outside of University of Virginia sites coming in and accessing our specialists.
Yeah, so right now, all UVA PCPs are on this platform. So basically, any UVA PCP who's on our instance of Epic has access to eConsults. We have decided to pilot with our geriatrics department to provide external eConsults during this time of COVID to some of our surrounding skilled nursing post-acute rehab facilities as part of a telemedicine package. So within that package, they get access to eConsults, they get access to telemedicine or traditional video visits. So it's part of a telemedicine package that we're doing. Right, we are getting ready to try this with Epic's CareLink, which is kind of an external facing platform for Epic.
A read-only tunnel, if you will.
Yes. And so we decided not to use an external provider for this, although we've done a lot of external provider kind of interviews and things like that, or external platform interviews, if you will. We at this time want to see if we can do it internally, but if we are super successful or we find that Epic CareLink isn't working, then we're open to using an external platform.
And there's multiple, as Kim alluded to, there's multiple vendors in the space. So it's just an institution-specific choice, but hopefully that answers that question.
Great, thanks. And the next question, are inpatient eConsults also sent via orders?
Yes. So our consult order, actually, there's just one consult order per specialty at UVA. So when you open up the consult order, say, consult to cardiology, at that moment, as one of the order-based questions, you'll select whether you think it's an eConsult or a regular consult. And then you're provided with the pager number of that consultant. And the protocol at UVA is that you would then submit the electronic order, which is kind of the documentation that the order obviously exists, but then you would also drop them a page with kind of the one-liner about the patient that you just ordered that consult on.
Great, and I believe you answered part of this question already during your presentation, but the question is, how are you handling those that do see the patient within the 14 days of the initial eConsult, practitioners seeing patients every day?
Yeah, so again, this is a really important point, so I'm happy to emphasize it. If the practitioner feels like they need to see the patient or needs to weigh in on that patient's case every day, you really should be doing a traditional consult, and whether that's with telemedicine, video or not, that's up to your institution. But the eConsult can only be billed every 7 days, and so you can accumulate time over the 7 days. So if you're, for instance, a diabetes doctor managing an inpatient insulin regimen, and you're kind of making advice every day about how to do that, you could drop that bill once at the end of your 7-day rotation and be like, I saw this patient, I adjusted their insulin, and I spent 15 minutes total doing it, and that could be part of your charge. Again, if a patient's acuity changes and you did an eConsult 3 days ago, but now you need to be much more involved in that care, then we would just do the initial consult, and our billing team would know to hold that eConsult charge moving forward.
Great. Next question, what percentage of your inpatient eConsults or IPCs are handled completely asynchronously, documentation only without the phone conversation?
So I would say that it's probably out of the, I don't know that I have the denominator with all consults, but out of the kind of asynchronous IPC e-consults, 85% of them are handled completely asynchronously. I unfortunately don't have the data yet for how many true consults were done last month.
Yeah, and I've only scanned it over with some fancy clinical informatics backup support, and I was going to say 75%. So I was glad to hear Kim guess there too. It'd be in the same.
So next question, is the specialist in a remote or separate physical location from the patient, and that's why you're considering this telemedicine?
Yeah, typically the specialist is in a different location than this patient. Yes.
And how are you billing for true consults if the key requirement of the exam is not able to be done due to service being done telehealth to prevent COVID spread and save PPE?
So we have a lot of endpoint devices in our telemedicine department that allow us to do physical exams. We've used devices like electronic stethoscopes and electronic otoscopes and things of that nature. So the nurse of that patient, of that inpatient, is kind of with the doctor afar, getting directions about, like, put the stethoscope here, let me listen, things like that. So those are being billed as full telemedicine, audio, video, visual visits.
Right. Are the physicians manually tracking time spent on eConsults, or do you have an automated way to track that?
Right now, we're manually tracking it. I wish we had the automatic capability, but we haven't been able to figure that out quite yet because these are done asynchronously. You might have somebody who has an eConsult open for an hour, but they are doing other things, and when you go and look at the documentation, it doesn't support the 60 minutes. So we haven't been able to do that yet.
All right, we had a question in the chat box that came in before the other question, so I'm going to go ahead and ask that. The question is, what is your experience with Medicaid coverage for pediatrics?
So as of this week, Medicaid has said that they would cover eConsults for all conditions, all ages.
Yep.
Prior to that, I don't know, it changed so many times, but we just got that notification yesterday.
Yep. Sorry. There's not.
I wish I had more information for you.
All right, the next question is, without having a template, are you just having them ask the medical questions in free text?
So, go ahead, Kim.
I was going to say, for the inpatient eConsult, that's true. They're asking just a free text question. Obviously for our outpatient eConsults, there's a template. They still are required to free text a question, but we've done a lot of work with everybody involved in this project to really talk about kind of like for lack of a better word, when you're talking like the medical school presentation question where it's like, this is a 46-year-old male with past medical history of X and coming in with Y, and this is my question, clinical question. They are free texted questions. We don't do drop downs or anything like that. But so far they've been pretty good.
And then just to say that there's also, for on the ambulatory side, there's the unspecified template, and so that helps us add new templates, or we monitor the template usage, and so we pull templates that aren't being highly utilized.
All right. Have you received any payments yet for IP eConsults? Are you monitoring by payer?
The billing department is monitoring by payer. I'm unsure if we've actually gotten any payments. I know we've submitted bills, but I'm not sure that we've seen anything come in.
Yep, that's exactly right.
All right, I think we have time for maybe one or two more. So one is inpatient eConsult something you plan to keep after COVID, or will it fade out?
I think it will remain active for some of our specialties. There are definitely specialties that have said, we've wanted this forever. This is great because, particularly, dermatology, they get a picture, they don't need to go up and see that patient, and they feel pretty comfortable with it. For other specialties, it will be a stopgap, and really, we're not going to need to change much to quote turn it off, because the specialist will always be able to easily convert it over to a regular consult, even if it's ordered as an eConsult. So it'll probably be something we keep on, but I suspect that each specialty will utilize it a little bit differently after COVID.
And just, I know we're running out of time. There's a couple of questions that have broader application that are easy to answer. Specialty to specialty, it totally can happen. Up until now, we had limited it to primary care to the specialist, but you have to be open to there being good use cases for it, like say ID and transplant, right? And so we're open to that. So if you're starting a program, you can consider that. It's not a hard and fast rule. But so far we haven't really advertised that. And then as far as pharmacy goes, pharmacy can be involved in it. I know that toxicology involves their supporting clinical pharmacist when it comes to things like urine drug analysis. So yeah, the pharmacy team can get on it to an extent too. Kim, do you have any thoughts on those two?
You'd have to talk to your billing and compliance team about pharmacy being able to bill for those, however, because prior to COVID, you had to be a MD or DO to bill for these.
Yep.
I know a lot of that has been relaxed in COVID times. I'm not sure that it'll stay relaxed. So I would definitely talk to your billing and compliance team regarding that question.
There's ways they can be involved, but the question is how officially and how billably. Yeah. Kathy, are there any more questions? I think we have a minute.
There are a ton more questions, but we are unfortunately out of time, and we will, hopefully we can post those to you guys after the fact and maybe have you answer them in a document, and we can post that document with the slide set and the recording. And I see nods, so that's awesome. Thank you so much. So Sam, if you can hit the next slide, we just want to thank you. This presentation has been part of the National Telehealth Resource Center webinar series, and we don't have the name or title of the next webinar, but we do have the date, which is Thursday, June 18th, 2020. So keep an eye out for further information and registration. And next slide. We really value your opinion and ask that you take a few minutes and complete our online survey, and let us know what you thought of this presentation and any other comments or feedback that you have. So thank you so much for your time, and thank you to Kim and Sam.
Thanks everyone.